It is Bairnsdale to Barouli, but I want to give you some background from an Australian perspective. What a surprise after our talks together yesterday that I should want to do that. The Australian Aborigine, our Indigenous Australians, we know have been on that continent for about 40,000 years. They have this marvellous legend about the creation of our mother, which happens to be Earth. The rainbow serpent was responsible for the construction of the Milky Way, as you and I know it. She paid particular attention to the creation of our mother, known as Earth, and particularly the inhabitants thereof, which are you and I. It's a wonderful legend and has been recorded in caves and rock walls, but there is somewhat of a white Australian perversion of one of their marvellous myths. And it involves something of the Australian shape. If we look at the map of Australia, there's a little bit down here called Tasmania, which would you believe is actually still Australia. Sometimes they get a bit forgotten. But the story is that the rainbow serpent became hungry one day and took a bite out of the bottom of Australia, regurgitated it up to create Tasmania. But herein is a geographical item known as the Great Australian Bite. That's geography. You might think of the Great Australian Bite as being something more along the lines of that. I can tell you that in 2017, 7 people died from crocodile bites. A lot more had crocodile bites, but 7 people died. We had 7 deaths this year from the great white shark. There are more than just a great white shark, and certainly many more bites, but 7 deaths. These snakes, don't we love snakes? Around where Kate and I live, these things are not that uncommon. However, I can honestly look you in the eye and tell you we don't see them very often, if at all, so they're not as big a worry as you might think. But 4 people died of snake bites this year in Australia. Dingoes, we don't see many dingoes, but certainly they are around. But I can tell you that in Australia we have on average every week 52 people treated for dog bites. So we're quite good with our bites. Here is the wound we're talking about today. Something that is derived from a bacterium known as Mycobacterium ulcerans. But when you see a wound like that, and like that, could there possibly be a relationship with bites, and particularly with bites coming from lovely cuddly things like possums and koalas, that may be not quite so cuddly? That's known as a Tasmanian devil. It does live in that little chewed up island that got spat out. If ever you want a definition of a psychotic animal, that is it. Beautiful and warm and cuddly for the first 3 months, and then after that, whatever happens genetically, it goes nuts. So if you ever want to cuddle a Tasmanian devil, do so before the age of 3 months. But you don't normally associate possums nor koalas with biting, and indeed they don't. Should you ever come down to Australia, please ignore the advice that some smarty pants Aussies might give you about drop bears. Drop bears are supposedly voracious, carnivorous perversions of koalas that just happen to fall out of trees and land upon you. That's a story for tourists, not really if you'd have to consider seriously. But let's look at this now as we come more towards the wound side of things. The Barouli ulcer is really Mycobacterium ulcerans. The Mycobacterium are a family of infections. We know them as causing tuberculosis, leprosy, and the 3rd most common form of Mycobacterium is the ulcerans, which causes the ulcers that we'll be looking at today. Barouli, well, that goes back to the 1920s. Where an English doctor was visiting Uganda in the city of Barouli and was describing the very things that you and I are going to look at today. But look, they've been described in many different parts of the world by different people, all of these things sharing the same clinical presentation that you and I are going to look at. The Australian words that pop up there happen to be Bairnsdale and Daintree. That again talks about our geography. The Daintree area is up in Queensland, up in the far north of Queensland. And that historically, particularly in the 90s and early 2000s, was a place where we seemed to have a lot of activity with these Mycobacterium infections. We also noticed that down the other end of the country, what a spread. Up here is the tropics. Down here is more temperate. And by the time we get down to Tassie, a little bit more like the climate you would know here. With all my talking yesterday, I'm going to do a bit more of this. What is interesting is zeroing in around Melbourne, down the bottom down here. Melbourne is the only Australian city which has appeared more than 3 times in the world's most livable cities, particularly in the last 10 years. I'm guessing nobody told them that in the last 10 years Melbourne or the areas around Melbourne have also been a highlight for an endemic of Mycobacterium ulcerans. I guess that didn't make it onto the criteria for world livable cities. So going back to the 30s, Dr. Searle, a general practitioner busy in Victoria, was noticing some of these ulcers taking place around the Bairnsdale area. But by the time his observations led on to Professor McCallum's work, it was actually one of Aussie's great claim to fame. It was actually these folks here who identified that these lesions, which had been seen in Uganda, had been seen around Brazil, elsewhere in the world, some subtropical Africa. It was actually Professor Peter McCallum who identified that it was the Mycobacterium ulcerans causing these kind of wounds. So let's bring you down to what's been going on very recently, 2016, 2017. Everywhere else in the world who has had a predisposition towards Mycobacterium ulcerans is gradually seeing their incidence of this kind of wound decline. We have got something else going on in Australia. For whatever reason, in these regions around Melbourne, our incidence of Mycobacterium ulcerans is going up. We have yet to really try to figure out exactly why that is. 72% increase in cases in 2016, and we already know that this year there's been another 50% increase on top of that increase. So something is going on down under. So when you come to visit, maybe choose where you come. What we do know is this bacteria, they tend to love swampy conditions. Anywhere where there is low light, low levels of oxygen, these are the warm, lovely places this bug tends to want to hang out. It's often found in soil, but here's a bit of another clue: possum and koala feces. Now, anybody who came to the workshop yesterday, you poor souls, and now you've seen this piece of news, would think that I'm somewhat poop orientated. It certainly popped up yesterday, and here it is again. What we do know is that there is no direct transmission between possums, koalas and humans. These animals don't bite you. They're not, by cuddling them, going to give you this bug. But what we now believe is their feces may well be resource pools of this bacteria. Our thinking is that it's actually the mosquitoes which, having come into contact with the infected possums and koala feces, is the vector that goes from that source to you as the human being. And that here is, either coming from soil or fecal material, the culprit. You look at the number of things that mosquitoes are responsible for around the world. Malaria right through now to ulceration. Goodness, they are not a friend, are they? The thing about these forms of ulcers and infections is it doesn't distinguish between anybody. Anyone who comes to these endemic areas is potentially susceptible. Its incubation period's fascinating, anywhere from 3 weeks to 12 months, but with an average of 5. So what this means is you can come to the Bellarine Peninsula south of Melbourne, enjoy a marvellous summer, have been bitten by mozzies 2 or 3 times, and it's not now until 5 months or more down the track that you might start to find a change in the infected, bitten area where the tissue starts to alter its presentation. You might start to see things like this: a wound on a knee, a wound over the Achilles tendon, the medial malleolus, and then over the instep area, just a lower shin of the foot. It can really occur in all kinds of areas, but look at the age groups too. Here is a 2-year-old, a wound on the ear, 12-year-old, a wound in the sacrum, a 9-year-old, a wound that exists on the lower leg. So the kind of wounds that can take place are quite nasty. And of course, isn't that sad to see youngsters with ulcers like this? So as we look at the Mycobacterium ulcerans, it starts off as a small spot or it can be under the skin, but what you may see is a colour change or edema. The big thing is these are generally painless. You would look at some of those wounds we just saw and you would think, man, that must be sore. But one of the clinical highlights is that these areas start as small spots, areas of discoloration, edema, and they have an unusual lack of pain. There is a sign worth picking up. As the wound progresses, you get undermining, you get tracts form. And it's quite possible that you can see intact skin, but as you insert a probe or a forceps or a gloved finger, you can actually find a tremendous amount of undermining, and you can actually probe to quite significant depth and distance, but yet skin is intact over the top. This is a slide from a dear mentor of mine, Donald McClellan, and a case that he shared. This is the kind of presentation you may expect initially, where you've got skin change, you've got a build-up of dense keratinocytes on the wound surface, but you've got swelling, you've got discoloration, and there is no pain associated with that. And this may last from weeks to months. But then as the wound progresses, you get these little areas of ulceration, and while the skin may look to be intact, in fact, there is tremendous undermining communicating between these wounds. Historically, what we've done is to find that the best way of intervening with these was thought to be a surgical approach. And that's what you see has taken place, a surgical excision of the affected tissue and then grafting. So for a long time, in the 80s and the 90s and the early 2000s, that was seen to be the preferred way of moving forward with these kind of wounds. But let's look at what other possibilities could cause wounds like this, because you do have to have a differential diagnostic approach. In sub-Saharan Africa, west coast of Africa, and northern Australia, we are experiencing an increase in Mycobacterium infection, but it's the leprosy version. And you need to make sure that if people are coming from these geographical reasons, that it may in fact not be leprosy itself, which is causing these forms of wounds that you're seeing. You saw some of them happened on the medial malleolus. One of our first impressions could be that, is this a venous leg ulcer? But yet it may not show all of the classic signs and symptoms of a venous leg ulcer other than its position. And if it doesn't respond to your treatment, if you were treating it like a venous leg ulcer, then maybe if it's not a venous leg ulcer, could it actually be something like the Mycobacterium? Fungal infections can certainly cause this, the good old sandfly bite, the leishmaniasis as well, and one of the interesting slides that Marco showed was the squamous cell carcinoma. We're quite big on those down under. Squamous cell carcinomas, basal cell carcinomas, melanomas. We tend to do that a little bit too well. But then spider bites. It was the one thing I didn't show you amongst the snakes and the sharks and the crocodiles. I didn't really mention the spiders then. We have two nasty ones. There's the funnel web spider. 4 people died from that this year. And then there is the redback spider. Nobody died from that this year, but leaves you with a nasty bite. But there is a spider down under that usually gets a fair bit of press. It's the white tail spider. There is tremendous debate as to does the venom from their bite cause you to have necrotic wounds or not? Or is it in fact that the spider bite, particularly living in soil which might be contaminated with Mycobacterium ulcerans, is the wound from the spider bite rather than the toxin? Is it the secondary bacterial infection which is causing the wound? So we're leaning more towards the fact that it might be the bacterial infection. How do you diagnose then what's going on? Well, the normal event is to look at the history and see what the story might be. Has somebody visited one of these endemic areas? Can they attest to having been bitten by mosquitoes or having been involved in soil with cuts or abrasions on their skin? You may take a biopsy and put it through the polymerized chain reaction analysis spectrum. And this particularly works well because you get a reliable result and reasonably quickly. Ultrasound may give us some idea as to the extent of undermining and tracking. But in Australia, if Mycobacterium ulcerans infection is identified, it is a reportable infection. And it must be reported within that 5-day period from diagnosis. What's causing the damage? It happens to be a lipid-based toxin called mycolactone. Quite nasty. It's very immunosuppressive and cytotoxic. And what it does do is it causes necrosis, as we've seen, and it happens in the fatty layer particularly and in the lower part of the dermis. But particularly in the fatty layer, you will find that the fat breaks down and it can do so leaving skin intact, which you have seen. And where it's in that fatty layer, you often get nerve disruption as well. And in fact, one of the things that mycolactone does do is it interferes with the normal chemical pathway in which nerve conduction takes place. Therefore, you're not getting the pain you would expect to get. It also dampens down white blood cells and disrupts your ability to produce brand new collagen, granulation tissue, and ultimately new skin. So mycolactone is a very aggressive toxin. It's aggressive because it can be associated with many negative outcomes. At skin level, we can be talking about extensive areas of scarring and contracture. With that, you may get significant loss of function of a limb or a digit. It has been identified, particularly if bites have occurred around the face, that it may actually cause blindness. There is an association with some cases where there's been osteomyelitis identified. We can see secondary lymphedema takes place if there ends up being extensive lymphatic involvement, and particularly this is the case if it happens around areas like the groin, the armpit, and also around the knee area. You might end up finding you're getting some lymphedema symptoms. Amputation, thankfully, is rare, as is death by sepsis. So these events are now far less common than they ever used to be. I mentioned to you that surgery, right up until the early 2000s, was the way forward. But they've now realised that as we've looked into the combination therapy of antibiotics, with rifampicin as the primary drug, these can all be added in various combinations, and it's usually always a 2-banger approach. But antibiotics can actually cure well over 90% of these wounds, so you don't necessarily have to go on and do any of the rest of this. But the normal treatment time is around about the 8 to 12 weeks. So there is your therapeutic time for antibiotic delivery. So it's continuously for 8 to 12 weeks. If the antibiotic seen alone is not sufficient, so this is now talking about 10% of those who have bites, then you may have to go on and have some surgical excision. But there was some interesting work pioneered in Cameroon, in Africa, because their ability to have access to all of these antibiotics is somewhat restricted, and their surgical expertise is not broad spread. They needed to look at another way of dealing with this infection. And what they've pioneered and have had good levels of success with is being able to apply topical heat. It needs to be done a bit carefully because you really are ramping up the heat. You are making sure that the wound is wrapped so that its temperature rises between 39 to 40 degrees, and you are sustaining that for 4 to 6 hours every day for what can be up to an 8-week period. It is a significant investment in time and resources as far as the logistics of you being engaged with them. But 4 to 6 hours each and every day of topical heat does take a fair bit of commitment. But they have shown a large success rate in the absence of having access to lots of these antibiotics in surgery. They have shown that, again, using this approach, the majority of their patients with these infections they can bring to resolution. Some data suggests that hyperbaric oxygen therapy may be useful. Again, there is a commitment of time over a fairly lengthy period. But for the vast majority, this is where the action is. If you're talking about using antibiotics, there is one little caveat to be said here, and that is that 1 in 5 people who are having intensive, aggressive antibiotic therapy may actually undergo what they call a paradoxical reaction. They've started on their antibiotics, you expect them to start to improve, but they don't. In fact, they can quite rapidly seem to decline. And they may not be overly happy with you because one of the first hallmarks of this reaction is the occurrence of pain. And with that pain, an increase in inflammation, exudate, and the wounds can often seem to extend. So what's going on? Well, when the antibiotics begin, what is actually taking place is that the mycolactone had made sure that it was stopping normal nerve conduction, so you didn't get the pain. The mycolactone was interfering with fat cells and also the generation of new tissue. But as the mycolactone is reduced, what happens is that with the antibiotics on board, there is going to be dead or residual Mycobacterium still left in the wound. But it's particularly the dead Mycobacterium left in the wound. Dead is what your antibiotics were starting to kill off. But now that the amount of mycolactone has been reduced, then it now means what mycolactone was suppressing is able to refunction, and your immune system, which was suppressed earlier, is now responding to dead cellular organisms within your wound. And as this intense response, your immune system is now activated, it's no longer suppressed, you will get these signs of inflammation and pain. How do you respond to that? Do you stop your antibiotics or not? Do you go on to surgery or not? You certainly increase your amount of analgesia, certainly. You may be dealing with the fact you've got high levels of exudate, so certainly you respond to that. But the idea is you continue your antibiotic therapy. You want to make sure that mycolactone, having been reduced, remains that way. And as you begin to have your immune system response breaking down these dead bacteria particularly, you carry on for an additional 4 weeks. So it means your treatment period might extend from 8 weeks to be going on now to 12 weeks. But the paradoxical reaction is self-limiting and it comes to a conclusion. You just need to press on. For the small number of cases, if the wounds are quite large, if the amount of tissue dysfunction is significant, or it's happening over vital areas like the face or the hand, you might want to limit further cellular damage by looking at surgical addition to your antibiotics. Here is a slide again that Donald shared with me. He got it himself from the ANZ Journal of Medicine. But here you can see that somebody is undergoing a surgical excision. They try and limit the amount of surgical excision to as much dead tissue as you can see, but you spare as much tissue as you can, which seems to have some degree of viability. And then grafting is often a way forward. Although what you will find shortly is the use of negative pressure, particularly negative pressure with instillation, is revolutionising this, and some of these wounds can actually close and not necessarily need grafting. So that is an interesting development. What are our forms of preventing this? When you come to Oz, please come. But if you're living in any of these endemic areas, far north Queensland, down south of Melbourne, be aware that it's worthwhile having some insect repellent. So bring your 44-gallon drum worth of it as you come on down. Having nets over your beds worthwhile, protective clothing, particularly at dawn and dusk and throughout early evening. And because we do believe that there is contamination in soil where the possums and the koalas are likely to live, if you're involved in gardening or you get cuts or nicks or abrasions, then do wash those areas well. Mosquito eradication sounds good, but it's not that easy to do. But having said that, one of the reasons that other areas in the world are decreasing their incidence of Mycobacterium, but we are not so successful with that yet, our incidence is increasing. There's been data out of Brazil to show that in those places where they are experiencing significant areas of deforestation, those endemic areas where deforestation is taking place, those warm, swampy areas are in fact drying out. They're becoming less moist. Their warmth is not retained. They are not the same wonderful environment for these mosquito species to live. That form of mosquito eradication might be at too great a cost. So we need to look at ways of how do we contain and deal with this. But it brings me to you now. We're here in the UK, not Australia. So this is all fascinating and interesting, but how does it affect what you do where you live? Borat, he could have been a great Aussie. However, Kazakhstan's fine. We'll share him with them. What we do know is that from 2003 onwards, the number of people arriving in the UK who may have been to endemic areas of Mycobacterium ulcerans infection, you have seen a gradual increase. Now, you're not seeing many of these cases arrive on your shores, but as we travel more and as some of these areas open up, and behold, if people arrive to you from south of Melbourne in Australia, having visited there as a tourist, if you were starting to see unusual areas of ulceration, they could be any age, any sex, anywhere on their body, you are seeing unusual lesions without the presence of pain, start to think, is Mycobacterium ulcerans a possibility? Because we are now a worldwide community. We're no longer that segregated. Some of the worldwide stats. 33 countries in subtropical areas, temperate climates, are known to report Mycobacterium ulcerans. Worldwide, we know there are up to about 6,000 cases reported. And most of them will occur, for your particular interests, within those returning to your shores from Africa. And so here you see a map. All these grey areas actually have reports of Mycobacterium ulcerans. As it becomes more and more blue, the incidences of Mycobacterium infection has increased. We should be making this rather more pronounced blue down around this area here, and that would then be more accurate. But you can see anywhere around Asia, Sub-Saharan Africa, and indeed South America and across into Mexico. Interesting that it's not reported so much in the Caribbean. But these are the places you can expect people may arrive from. Now, interestingly, what's been identified recently is that particularly in the African countries, it may just not be the mozzie which is the culprit. They have identified that there can be a number of waterborne arthropods, but this thing here, the Mucorus, is now being identified, particularly in sub-Saharan Africa, as a major contributor to biting you and spreading that infection. So our summary slide. Should this wound occur, it is slow to progress. It can be weeks or months to see it decline. It is painless. It may not be associated with a causative event. You may not be able to think, oh bugger, I got a mosquito bite in Australia. I had a Mucorus bite over there in Ghana. You may not find that you can identify a cause. It can certainly occur in younger people. And then as we come on down that list, it can be associated with some of these other findings. Anecdotal reports in recent months suggest, other than the antibiotics, getting our diagnosis right, looking at the concept of local heat that they're doing in Cameroon, there are reports of some degree of success with symptom control with cadexmariadine. Larva therapy may have a real role to play here when it comes to getting rid of the dermal and fat necrosis. And then, as we've seen, when it comes to reconstructing these wounds, negative pressure with some instillation therapy particularly is a way of controlling infection, reducing the immune system response so you don't get the aggressive re-inflammation and pain, and then of course getting that granulation tissue generation. That's the kind of wound we're hoping not to see, or if we do, we now know what we might be able to do about it. And there are 3 slides of references, which I'm not going to subject you to, but it's just to let you know I didn't make it all up as I went along. And thank you for your time today.